Hi, good evening and welcome to this CPD Me webinar. My name is Andrew and I will be facilitating tonight's webinar, and I'll very shortly be handing you over to Dr. Darshana talking all things abdominal pain in kiddies. So before we go anywhere tonight, I'm just going to tell you a few facts and figures. We can't hear you and we can't see you. So if you're sat there in your boxer shorts, or maybe you've just come out of the shower with your satin robe on, then don't worry, because we can't see you, and equally we can't hear you. You probably have noticed that they've moved me tonight in the office. They've put me in a completely different position and it's thrown me off. So background looks all quite exciting tonight with company logos. Looks very corporate, in fact, doesn't it? So if you have any questions for Dr. Darshana tonight, please do use the questions and answer box, and I'll sift through those and we'll answer them at the end of the webinar. But as always, if you are online tonight with us, then please do use the chat function to tell us where you are, maybe tell us where you're dialing in from, and maybe tell us what your experience is of dealing with kiddies with abdominal pain, and I'll share one of mine at the end of tonight. If you are a member of CPD Me, then you will get a CPD certificate, and that will come automatically to you in the morning, and that will arrive also in the mobile app, so you can go in there and you can reflect. And what I am going to do at the end, once Dr. Darshana's finished, is I'm going to show you what it looks like when your certificate arrives in the mobile app and how quickly you can reflect and create a perfectly piece of CPD. And of course, everybody will get a copy of the recording, and we're also live on YouTube, so you'll be able to jump onto YouTube if you need to catch up on tonight's CPD. There will be some opportunity tonight to scan QR codes. So if you are tech savvy, you can activate your QR code scanner pointed at the screen, and you should have some clear call to actions, I think the posh term is for it. And so we can try that now, because you can, if you haven't already done so, download our amazing new CPD Me mobile app. You scan that QR code and that will download from either the iPhone App Store, whatever, I don't even know what they call it. Is it Apple Store, iOS, I think, or even you can download from the Google Play. And we've also got an iPad app and an Android tablet app available too, so you can capture and record your CPD on the move. And I will again demonstrate the app to you at the end of tonight's webinar. As always, we do love to see what you're up to on social media. In fact, I think I did this the other night, but if you're sat there tonight with your dog on your knee, or your parrot on your shoulder, or your I think I use the analogy snake on your lap today. But whatever you've got pet-wise, please maybe take a selfie tonight, share it on social media at CPD Me. If you're not following us at CPD Me on Twitter, then please do, because all the latest gossip around CPD Me and what's coming always goes on Twitter first before we blast it out to members. So it's a good place to be in the know. And if you do copies into a post tonight, then please use hashtag CPD Made Simple, and then we can follow and track that down. If you struggle keeping an accurate record of your CPD like I did back in the day, then please do consider becoming a member of CPD Me, because you can have a 30-day trial for just £1.99, and you can completely get your money back in 30 days' time. You think this is not for me, but it really is a super quick and accurate way to record your learning and development. More importantly, when you use the mobile app, it takes you less than 2 minutes to capture evidence and make a reflective entry. So please do consider joining us as a member. And as a premium member, you get 80 live webinars with automatic certificates. So that means tomorrow your certificate drops into your portfolio automatically with a title and a date and the evidence, and all that's left for you to do is reflect upon your learning. We've just took our 1000th doctor on board this week, and so we've got lots of GMC people who are currently grabbing our app and revolutionizing the way that they record their CPD. So whether you're NMC, HCPC, GMC, ABCD, EFG, then please do download our app and consider becoming a premium member. And you can scan that QR code for £1.99. I think you can buy a cup of coffee for that in this day and age. If you're not subscribing to us on YouTube, then please do consider doing so, because every time we upload a notification or a video on YouTube, you'll get a notification. So this week, I think we've put a video on there around how to share CPD, because another benefit of being a member is we have a shared CPD section on the dashboard. So we have about 50,000 people who share CPD on that platform, which is completely free of charge. So if you're struggling for some inspiration, you can go into the shared CPD bit of the website, and literally there's hundreds and hundreds and hundreds of learning and development opportunities that are free of charge that other members have shared. So please do consider subscribing to us. Some great videos on YouTube, and you don't want to miss out. We like to give away some giveaways on these webinars. So we always ask for genuine, heartfelt reviews on either Trustpilot, the App Store, or Google. And so you can scan that QR code, or I'm going to pop some links in the chat as we get going. And if you leave us a genuine review tonight, I've got £325 Amazon vouchers to give away, which we will give 2 of them away tonight live, and we'll give 1 away tomorrow on Twitter for anybody who leaves us a review before tonight's webinar finishes. Again, we've got our QR code poster, and I've seen on social media this week a couple of people have posted February's poster on there, and every single month we give away a Amazon voucher to somebody who has shared a picture of our CPD posters on their works notice board. The strangest place I've seen one is behind a toilet, so in a toilet as you sit down, there was one of our posters there. There is stranger places to put a poster, but that definitely won a £50 voucher. So we give away a £50 voucher once a month to anybody who we see on social media has got one of our CPD posters up there to help promote our free learning and development. If you want to subscribe to the poster, you can scan that QR code, or if you just put in the chat, subscribe me please, and we'll get one of the team here tomorrow to subscribe you to our posters, which means every month you get a fresh poster ready to distribute. That's enough for me now, because I'm all dried-mouthed. So I'm going to hand you over to Dr. Darshana. Are you there, Dr. Darshana?
Yes, I am, Andrew. Thank you.
Fabulous. It's all yours.
Great. So am I able to share my screen? Great. All righty. Great. So thanks again, Andrew, for inviting me back to deliver another webinar this evening. And good evening, everybody. Thanks very much for joining me this evening. My name is Darshana Bhattacharjee. I'm a paediatric consultant based in South Wales. And this evening, I'm going to do a session on abdominal pain in children. So I'm hoping that by the end of the session, you'll be able to do a rapid ABCD assessment of acutely unwell children. Those of you that have joined my webinars previously know I'm a big fan of this kind of assessment. Those who are not, I'll do a very rapid 1-slide overview of this when we start. I also hope that by the end of the session, you would be able to distinguish between acute and chronic causes of abdominal pain a little bit better, and recognize common surgical emergencies that turn up in children. And at the end, we will talk briefly about recurrent abdominal pain and how to manage this. So I'm going to start by, as I said, quick overview of ABCD, but then just chat through some causes of abdominal pain. Then the main portion of the session will be 4 case scenarios. Then, as I said, we'll do an overview on this fairly new entity called recurrent abdominal pain that can often throw up diagnostic conundrums, especially in primary care. And I'll finish with some resources to direct you to for further reading and study. So first of all, just want to go through my favorite way of assessing a sick child. It's as simple as ABCD, as you can see here. And essentially this gives you an idea of how seriously unwell a child is. And the reason why I like this structure is because firstly, it's easy to remember. And secondly, it makes it very clear what you have to address before you move on to the next one, because obviously problems with the airway will kill you before problems in breathing and circulation and so on. Excuse me. So this is quite a general overview, but even if you see a child who is perhaps not presenting with an immediate life-threatening airway problem, but if they are sick, it is still important to go through this process, I feel, because you may well turn up with problems that you didn't anticipate, and then it just makes your assessment and your treatment a lot more thorough. So A stands for airway, obviously. Does a child have a patent airway, or is there any signs of partial obstruction from a foreign body or mucus, or any noises such as stridor, which is an inspiratory noise that might indicate a partially obstructed airway? Be mindful that if a child is unconscious, they are not protecting their airway, so you do need to do certain airway maneuvers to make sure that the airway is safe and the child isn't at risk of vomiting and aspiration. B is your assessment of breathing. And again, those who joined me for my breathing problems in young children know that I like a kind of top-down systematic approach to looking at signs of work of breathing. But in children, things that are quite particular to young children are noises like grunting, which is an expiratory noise against a partially closed glottis. Central cyanosis, which is really difficult to pick up, but if you see a child with kind of central blueness of the tongue, then this would indicate their saturations are likely below 85%. And obviously looking at their respiratory rate, tachypnea, and this does vary according to age, but generally any child who's got a respiratory rate of over 60 is working hard. And then you want to obviously look at their chest wall for signs of recessions, retractions, again, to indicate work of breathing. And that's even before listening. Assessment of circulation in C is particularly important in young children because they can compensate up to a point and then suddenly deteriorate. So if you look at the child, they might look pale or very mottled. If you touch their skin, they might have cold peripheries. You'd want to measure their heart rate. Again, heart rate ranges vary according to age. You may well need to ask a parent how frequently they're passing urine because reduced urine output is a sign of impaired circulation. And you want to check central capillary refill time rather than peripheral. So if central capillary refill time, which you test by pressing on the sternum for 5 seconds with your thumb and then letting go, if that's greater than 3 seconds return, then that is prolonged. But take that in context with all of the other signs. D is for disability. Now, in children who are old enough, you can probably do a Glasgow Coma score, and that again is modified according to age. But things again that are quite particular to children are whether they're floppy. So if they're hanging down like a rag doll in their parents' arms, or if they're lethargic, or if they're not responsive. And you can use your AVPU score if you're familiar with that. So alert, responsive to voice or pain, or unresponsive to get an idea of their GCS. In infants under the age of 9-10 months, they may have an open fontanelle, so you want to feel if the fontanelle is level or bulging, because that's a sign of raised intracranial pressure, and any signs of neck stiffness that might indicate a kind of meningitis picture. And finally, E for exposure, which is where the majority of today's scenarios come into, but still be mindful to do everything else before it. That's where you expose a child adequately, but fully, see if there's any rashes, any skin changes, take their temperature, and you'd want to look at and examine their abdomen for any signs of obvious distension or tenderness. So for me, this system is really nice because it just keeps everything in check and has a good flow to it. Obviously, in real life, you might do some of these things simultaneously. It just depends what you're comfortable with. So then going on to causes of acute abdominal pain. So as you can imagine, in children, there's really a multitude of causes, and they can be vaguely subdivided into surgical causes, which are listed on the left. Now, I'm not going to go through each and every one of these in detail, but over the course of the case scenarios, we will talk about some of these things. And then you've got medical causes in the middle column, which are intra-abdominal causes, so due to actual pathology within the abdomen. And then on the right-hand column, you've got extra-abdominal causes of abdominal pain, which sounds a bit weird, but basically children are quite poor at localizing pain. So again, quite peculiar to pediatrics, children who have a lower lobe pneumonia, for example, can actually complain of abdominal pain. And you just have to be a little bit savvy and look at the signs to really get an idea of where this is coming from. In boys, you must always check their testicles if they're complaining of abdominal pain, obviously with a chaperone present, either a parent with consent or another healthcare professional, because testicular torsion, if it's not diagnosed, can quickly lead to loss of a testicle. And you can get musculoskeletal causes of possible referred abdominal pain, really. And then just to mention that within the kind of medical causes of abdominal pain, the acronyms there. So you've got HSP, which is Henoch-Schönlein purpura. That's essentially a vasculitis that can manifest in various different organ systems, most commonly as a raised red rash on the lower legs, but you can have renal complications and gastrointestinal complications as well. DKA is diabetic ketoacidosis, so that's essentially in children who have type 1 diabetes with uncontrolled blood sugars, often a first presentation of type 1 diabetes, and these children can have abdominal pain from, from the osmotic shifts with the glucose and vomiting. And IBD is inflammatory bowel disease, and again, we'll talk about that in a little more detail throughout the course of the presentation. So as you can see, these are all causes of acute abdominal pain. When we talk about recurrent abdominal pain or chronic abdominal pain, I'll go through those causes separately then. So without further ado, let's launch into the case-based scenarios where we can get stuck into some of these conditions a little bit more. And I've tried to make this a little bit interactive with some Zoom polls, so please get involved when we get there. So the first case. So a 7-year-old boy comes home from school complaining of central tummy pain that he describes as coming and going, and he feels sick. He doesn't want his dinner and he lies down on the sofa. After about an hour, he says that the pain is getting a lot worse and it's actually moved down and into the right side of his abdomen. And when he gets up, his parents notice that he's bent forward and has real difficulty walking. He's really uncomfortable. He then has a large vomit despite not eating anything and just looks really pale and unwell. So his parents get quite worried and take him to the out-of-hours GP. Of note, he's normally fit and well young boy with no past medical history of note. So the assessment I'm going to put in an ABCD format just for ease. So at the out-of-hours GP, the GP who sees him has a little look at him. His airway is patent. He's talking, he's responding. On examination of his breathing, he's got mild tachypnea, which is likely due to the pain that he's in, but no obvious signs of respiratory distress, and his chest sounds clear when it's listened to. On assessment of his circulation, his heart rate is 132, which is a little bit high for his age, but his blood pressure is 100/65, which is fairly normal. Again, probably a little up because of pain. He is warm and well perfused, and his central cap refill time is less than 2 seconds. In the disability section, he's alert, but he's crying in pain. And on exposure, his temperature is slightly raised at 38.2, and the GP feels that he's got diffuse abdominal tenderness with point tenderness in his right iliac fossa, RIF. So he's got point tenderness in that right lower area. So based on the assessment and the information you've got so far, what do you think is the most likely diagnosis right now? So Andrew, if you could put up the MCQs for case 1, please, onto the polls.
I will. They're live now for you on screen.
Lovely. So everyone just have a little go. Please pop your answer down. It's all anonymous, and we'll see where we get to.
Okay, we'll just do a couple more seconds. 5, 4, 3, 2, 1. There we go.
Lovely. Good stuff. So the vast majority of you said appendicitis, sorry, and small number said urinary tract infection. But brilliant. That's great. So nice, easy one to start with. The most likely diagnosis in this case is appendicitis. So next steps would be fairly straightforward. You'd want to refer this young boy to the local surgical team. It doesn't necessarily have to be pediatric surgeons per se. Certainly within the UK, most adult surgical teams are quite accustomed to operating on children over 5 with appendicitis, as long as they've got the anaesthetic support and the expertise. And appendicitis is usually a clinical diagnosis. So from the kind of GP end, really, blood tests are not necessarily needed. It's useful to have a urine dip to exclude a UTI because some children do present with abdominal pain and vomiting as the first kind of symptoms of a UTI if they're too young to complain of dysuria. But certainly, blood tests aren't necessary. An ultrasound scan in hospital may support the clinical diagnosis, but often it's very operator dependent and the appendix is not always seen, particularly if it's retrocecal or just the anatomy is a bit different. Surgical intervention can either be laparoscopic if it's fairly straightforward, or an open laparotomy might be needed if there's complications such as perforation. And perforation can happen quite quickly, leading to children becoming quite sick with sepsis and peritonitis. And if this is the case, if this young boy, for example, had a more indolent course or hadn't been seen for a couple of days, and then his appendix perforated, he'd need fluid resuscitation with intravenous fluids and antibiotics ahead of surgery. So I'm hoping that the majority of you are quite familiar with appendicitis. So you've got the appendix, which is at the lower end of the cecum. It's a vestigial organ, which means that we don't really have any use for it. Why it inflames and gets angry, we're not entirely sure. Sometimes it can be related to fecaliths or hard little solid lumps of poo, especially if kids are very constipated. But really, there's not that much of a connection there. It is the most common cause of childhood abdominal pain requiring surgery in kids over the age of 3, but it is very, very rare in children under 3. So if kids under 3 present with acute abdomen, think of other things, which we will talk about. And the classical symptoms are usually presenting with anorexia, so not wanting to eat, vomiting, and this very classical pattern of abdominal pain that starts centrally and is colicky, meaning it comes and goes, and then moves and is localized to the right iliac fossa, which is where the appendix is located. And it is associated with a fever, so don't be surprised there. And as I've said, complications of appendicitis includes perforation, but can include the presence of an appendix mass or an abscess in some situations. So regular review of these children is important, particularly if the diagnosis isn't terribly clear. And this is where an ultrasound might be useful. Blood tests might show a raised white cell count, but again, that's fairly non-specific. And important differentials to be mindful of are things like mesenteric adenitis, which is not a surgical condition. Mesenteric adenitis basically describes enlarged lymph nodes in the intra-abdominal cavity, and these can become enlarged from, for example, viral illnesses or any other illness, and sometimes can be very, very painful. They can actually mimic the pain of an acute abdomen, but it's just something to be mindful of. It might be difficult to distinguish clinically sometimes. So again, this is where something like an ultrasound might be needed. Always check inguinal hernial orifices, for inguinal hernias, particularly in boys, because a strangulated inguinal hernia can lead to vomiting and abdominal distension. It's essentially a type of small bowel obstruction. And as I've mentioned earlier, make sure you examine the testes in boys with chaperone for the examination to exclude a testicular torsion. That's a pretty easy one to start with, which is great. So we'll move on to the second case. So the parents of a 2-year-old girl called 999 because she's been screaming in pain and has just passed blood in her nappy. During the day, she's been having intermittent episodes of inconsolable crying. She's also been vomiting and hasn't really passed any stools in the last 2 days. Her parents did take her to the chemist where she was given some oral rehydration solution for the vomiting, but she's not been able to take this at all. She's vomited it straight out. So when the ambulance arrived, the paramedic crew assess her. They feel her airway is patent. She is crying her head off, bless her. And the respiratory rate is slightly raised at 45. She's got a bit of mild subcostal recession, so indrawing underneath the ribs, but her chest sounds clear. But when they assess her circulation, she's quite tachycardic at 165. They have difficulty measuring her blood pressure because she's agitated and crying and moving around. But her peripheries feel very, very cold. Her hands and feet feel very cold. And her central capillary refill time is about 4 seconds. And she looks very pale. On D, when she's not crying, she becomes very lethargic and is only responding to voice. And her blood glucose, when it's checked, is 2.9 millimoles per liter, which is low. So normal cutoff for children is 4. And when they take her temperature is low at 35.6, and her abdomen looks very distended and feels very tender. So based on this picture, what is your top differential at the moment? So Andrew, if you could pop on case 2 MCQs, please.
There we go, that's live on screen.
Lovely. So have a little think with the history and the examination. I know it's not huge amounts to go on, but what's kind of jumping into your head out of these potential differentials?
Okay, we'll leave it for a few more seconds. 5, 4, 3, 2, 1. Okay.
Great. Okay, so a bit of a mixed bag, but just over half of you have said intussusception, about a quarter said constipation, and then a couple have said pneumonia and DK. Fine. So for the 53% of you that said intussusception, well done. That is certainly the top thing that we're thinking of here. So really, this child is sick. They are essentially, from the assessment, if you can remember, they're shocked and they've got signs of potential bowel obstruction. So really, if you're able to, and they're also hypoglycemic, I forgot to say, you'd want to treat them immediately for their shock and hypoglycemia by giving them an intravenous fluid bolus of a crystalloid like normal saline and a bolus of 10% dextrose as per the advanced pediatric life support guidelines that we use here. And this child then needs to be transferred urgently to the nearest pediatric surgical center, essentially to confirm the diagnosis with an abdominal ultrasound scan, and we'll talk shortly as to what that will show. And if this confirms intussusception, then to have a reduction of the intussusception by certain means, again, which we will talk about shortly. But this is a very time critical scenario, so really no delays can be made. So what is intussusception then? So essentially, intussusception is a condition where part of the bowel, be it large bowel or small bowel, telescopes into another bit of bowel, as you can see in this little diagram here. It can occur at really any age, but the most kind of peak age of presentation is between 3 months and 2 years. And causes of it can vary. It can be idiopathic, but essentially it can result from a lead point in part of the bowel. Now, this can be caused by something like a polyp or a Meckel's diverticulum, which is an embryonic remnant of the vitellointestinal duct. It's basically a kind of embryonic thing. But most often, the lead point is due to enlarged Peyer's patches, which are patches of lymphoid tissue that line the bowel. And if they're inflamed due to, for example, a viral illness or Henoch-Schönlein purpura, then that can essentially lead to a point where the bowel telescopes and gets stuck. The bowel can telescope anywhere, but the most common point of intussusception is at the ileocecal joint. So it's basically where the small intestine telescopes into the ileocecal joint, and then that's where it gets stuck. And symptoms are essentially caused by the subacute bowel obstruction, and if it's left for too long, the bowel becoming necrotic. So symptoms and signs that you see in children is this severe colicky abdominal pain with notable pallor during these episodes. So children pull their knees up to their chest and scream, and they become very white, especially around the mouth. They may well vomit. If you think about partial or complete bowel obstructions, the vomiting may become bile stained as well, depending on the level of the obstruction. And children often pool a lot of fluid in their intra-abdominal cavity, which leads to hypovolemic shock. They may well have abdominal distension, and you may feel or see a sausage-shaped mass in the upper abdomen where the bowel telescopes into another bit. This is not that common, and sometimes an intussusception can be intermittent, and it can come and go, so to speak, and that's very difficult diagnostically. And a very late sign is something called red currant jelly stool, where basically the bowel has become stuck within itself for so long that the bowel mucosa sloughs off. And essentially that's what the red currant jelly stool is. But you're essentially, on the way to necrotic bowel at this stage. And that's very much a sign that the bowel is potentially about to lose bowel. A little side note that intussusception is a great mimicker as well. So I've seen children with intussusception who actually have diarrhea rather than not opening their bowels at all. So really, you need to have a very high level of clinical suspicion that a child might be presenting with this. So what I would say is that if you see a child who has pain out of proportion to what you think they have, so if they're having these severe episodes of pain and screaming and pallor, and are vomiting more than usual, and just don't look well because their circulation is becoming impaired, and they're in the right age group, kind of under 2, under 3 sometimes, then really just don't delay. If you think it's an intussusception, then go ahead and get an abdominal ultrasound scan if you can, which is the gold standard. And I'll show you a picture of a scan on the next slide. These children invariably need intravenous fluid resuscitation because they are leaking fluid into their intra-abdominal spaces. And once the once the intussusception is diagnosed, then reduction is either by an experienced person who is doing the ultrasound scan, an experienced radiologist who can do a technique called rectal air insufflation, where essentially air is pumped up into the backside, which then gently pushes out the telescope bit of bowel. Now, this is obviously not without its risks. One of the greatest risks is perforation. So if this procedure is undertaken, it has to be done in a center that does have pediatric surgical specialties and a pediatric intensive care. So it means that, for most of us, it's going to be sending the child to a big tertiary center. As I mentioned before, it's a time critical lesion. So if the longer we leave an intussusception undiagnosed, the more likely a child is to have a necrotic bit of bowel with a bowel resection and some kind of stoma. So it really is an important diagnosis not to miss. So this is the ultrasound scan. Now, I know to me ultrasounds look like gray blobs within gray blobs, but I'm hoping you can see what is the target sign, or the donut sign, which is basically a kind of cross section of one piece of bowel telescoped into another piece. So 2 rings. Hopefully you can all see that right in the center of the screen, where there's one bit of bowel and then a dark ring around it. So that's the diagnostic sign for an intussusception on ultrasound. Great, so that was intussusception. So we'll move on to our third case. I think I'm doing all right for time. So a 12-year-old boy, this time a slightly older boy, is taken to his GP with a 3-week history of abdominal pain, diarrhea, and lethargy. His parents are quite concerned because he has visibly lost weight, and he doesn't have the energy to play football, which he absolutely loves. He's playing football most days, he's part of the school team, he's out every weekend, and he just doesn't want to do that. He says that he thinks his pain is worse after eating things like pizza and pasta, and he reluctantly tells you that he's quite worried himself because he's actually been passing blood with his stool several times over the last 2 days. So when you assess him, his airway is patent, but when you look into his mouth, he's got quite a lot of aphthous ulcers on his tongue and his inner cheeks. His respiratory system is fine. He doesn't have any distress. His chest is clear. And his circulation, again, pretty stable. His heart rate is 90 and his blood pressure is 110/70. His heart sounds are normal. He is alert. His blood glucose is actually within normal limits, despite him not eating as much. But when you expose his abdomen, his abdomen is diffusely tender, but it's not distended. He's not guarding, but he's got some raised purple nodules on his shins. So he's got a funny looking rash on his lower legs. And he swears they're not from playing football because he hasn't been playing football for several weeks now. And his temperature is 37.2. So you do some more tests because things aren't really that clear at the moment. So you send him away. So you don't send him away, sorry. You first of all plot his growth. And it's very obvious that his weight and his height have fallen 2 centiles over the last 6 months, which is unusual for a 12-year-old because you often should be seeing a growth spurt then, but there's no signs of a pubertal growth spurt at all. He's not started any signs of puberty. And you do some baseline blood tests, which his full blood count shows a low HB. I'm not giving you exact numbers on purpose, just because it's not that important here. But he's got a low hemoglobin, which is a microcytic picture, and he's got raised platelets, a raised CRP and ESR when you do his inflammatory markers, and a low albumin on his liver function tests. You send off a stool sample for microscopy and culture. It's bloody, but there's no signs of any infection or any infective organisms grown there. And you manage to get him an abdominal X-ray, which shows possible thickened loops of small bowel, but it's a little bit tricky to interpret, as abdominal X-rays always are. So, given this set of information and his history and examination, what could his possible diagnosis be, do you reckon? So, Andrew, case 3, MCQs, please. Thank you.
Okay. I'm frantically writing all these people's names down who's left his reviews on Trustpilot.
Yeah.
So, thank you, Chelsea. That was your name just written down. 5 more seconds. 4, 3, 2, 1. There we go. Great.
Oh, this is interesting. Right. Really starting to flummox you guys now. Great. Okay. Well, 60% of you said celiac disease, and about a third of you said inflammatory bowel disease. Here, I'm afraid the answer is the most likely diagnosis actually in this scenario is inflammatory bowel disease, and I'll tell you why. So, inflammatory bowel disease in children, the incidence is increasing. It's about 5 per 100,000 per year. And Crohn's disease, CD, is twice as common as ulcerative colitis. We don't know the exact causes of inflammatory bowel disease, but there's certainly a genetic predisposition, and there is some complex interplay between gut microbiome and mucosal immunity, which is probably why we're seeing an increase in the incidence as well. But inflammatory bowel disease is divided into, as you, I'm sure you're already aware, Crohn's disease and ulcerative colitis. Now, the diagram on the left is a kind of pictorial depiction of Crohn's disease, which essentially may affect any part of the GI tract from the mouth right down to the anus. But the terminal ileum and the proximal colon are usually the most common areas. And as you can see in the diagram, where there's a stricture labeled, that's the kind of terminal ileum and the kind of ileocecal junction there. And the most classical presentation of Crohn's disease is usually abdominal pain, diarrhea, and weight loss. But kids are often malnourished, and they're not growing very well, and they can have some extra intestinal manifestations, which I'll talk about on the following slide. And age of onset, kind of slightly overlook this age of onset because this diagram is from the kind of Crohn's and Colitis UK website, which is quite widely, quite a wide audience. But age of onset is kind of early teens. Ulcerative colitis, in contrast, tends to present in slightly older children, and it involves the colon only. And usually proctitis is the most common manifestation of disease, and certainly bloody stools are a lot more common in ulcerative colitis as well. And complications are a little bit different here as well. So just be mindful that the two entities that make up inflammatory bowel disease, that there are some important differences between the two. So the extraintestinal manifestations in Crohn's disease include oral lesions like the aphthous ulcers, perianal skin tags. I've seen children where, you know, we've literally diagnosed Crohn's disease just by looking at their bottom, which sounds awful, but you know, they've got such bad perianal disease, you know, that's how, you know, they often get the diagnosis. Uveitis, which is eye disease, arthralgia, so joint pains, and this classical raised rash, erythema nodosum, that you often see on the lower legs. But really, growth failure and delayed puberty are hallmarks of Crohn's disease in children, hence why this 12-year-old's growth chart was so telling. So it's always really key to plot height and weight in children who have a slightly longer history of illness. Diagnosis of inflammatory bowel disease tends to be made on endoscopy and biopsy rather than bloods itself, but blood tests tend to show a kind of a general inflammatory picture, such as a microcytic anemia, raised platelets, raised CRP and ESR, and classically low albumin as well. So kind of very, very classical changes. I did throw you a little bit with the pizza and pasta thing. I think that's why some people went down the celiac route, but it's more a reflection of heavily processed foods leading to some of the symptoms that we see, really. And management, as you can imagine, requires a specialist multidisciplinary team. So these children are invariably referred to pediatric gastroenterology teams. I'm not going to go through the ins and outs of treatment because it does tend to be managed by the gastroenterology team, really. But main principles for children are to maintain their growth, and this is usually done by diet. Now, we used to do kind of elemental diets for children with Crohn's disease and ulcerative colitis, but we don't do that anymore. In fact, you know, a kind of a healthy, balanced, mixed diet, sometimes a blended diet, if children are needing supplemental nasogastric feeds or gastrostomy feeds, is actually far better than kind of elemental supplemental milks and, you know, different products like that. But Crohn's disease, you know, is typified by relapses and remission, and the whole kind of aim of treatment is to treat the relapses with things like steroid medication, anti-inflammatory medication, and then maintain remission with immunosuppressants. But if they don't work, then biological therapies like anti-tumor necrosis factor agents, like infliximab. So these are all done within hospital in day cases. So that's why I'm not going to go through these in lots of detail for you right now. Some children, unfortunately, will have complications of disease. For Crohn's, these can be particularly nasty, like fistulas and abscesses, and children might need treatment for that. And particularly severe disease, such as toxic megacolon in ulcerative colitis, might lead to a young person having a total colectomy, which is pretty terrible for them, because that leads to kind of long-term problems as well. But you know, things don't stop there. You know, certainly children with ulcerative colitis do need screening in adulthood for you know, potentially developing adenocarcinoma of the colon. So they usually are kind of reviewed every 10 years or so with a colonoscopy or an endoscopy. So not a nice disease at all, and it's a pretty tricky one to diagnose sometimes. But there are good resources out there to support children and their parents, such as Crohn's and Colitis UK. That's a really good one to refer families to if they need it. So we're going to move on to our fourth and final case. So a 4-year-old girl is seen by her health visitor. She's only opened her bowels twice in the last 3 weeks, and she's been having tummy pain and eating less than usual. Parents say that she's fully toilet trained, but has recently been having some accidents in her underwear. And she was recently treated for a urinary tract infection with some oral antibiotics. And now I just want to say that this picture does not look like a 4-year-old, I know, but I wasn't terribly consistent between the picture and the case. So I apologize. Let's pretend she's 4 and not 18 months. So on assessment, the child looks well grown. There are no signs of anemia. So I'm not doing this in an ABCD format just because the rest of her is very well. And looking at her abdomen is actually quite soft, not distended, not tender. But the health visitor can feel a kind of soft indentable mass in the lower abdomen. The child's spine looks normal. She was walking normally, and she's been reaching her developmental milestones absolutely normally as well. So with the information that you have to hand, I admit it's not that much information, but what is the most likely diagnosis right now? So Andrew, it's case 4A MCQs.
Okay, we've definitely got a majority vote. Okay, we'll give you a few more seconds. 5, 4, 3, 2, 1.
Lovely. This one was a bit of a no-brainer, I think. So yes, the vast majority of you did say constipation. I threw in Wilms tumor there. That's actually a type of kidney tumor. But you are correct. It is constipation, absolutely. And on further questioning of the parents, the child eats quite a low fiber diet and not that much fluid, maybe about 200 mils per day, they think, but mainly milk. And she's become quite scared of sitting on the toilet because she says it hurts. She has a history of constipation about 6 months ago, which did improve with some changes to her diet. And you do ask about birth history, and she passed meconium within the first 24 hours of life. But parents say there is a family history of bowel cancer. So with this information at hand, what do you think is the next best step for this child? So Andrew, questions 4B, please.
Okay, just a few more seconds. Again, majority vote coming in. 5, 4, 3, 2, 1.
Okay, lovely. So the majority of you have said encourage increased fluids and fiber in the diet. And then next after that is start laxatives. Lovely, thank you. So I'm going to confess this was a bit of a trick question, because actually there's a few things you can do at the same time. But in this scenario, given the fact that you can actually feel a lump of poo in her abdomen, she's likely fecally impacted. You definitely need to start laxatives in this scenario. And I will tell you why shortly. It is definitely correct to increase fluid and fiber in the diet, and you'd want to encourage a good toileting routine as well, but simultaneously and not as first line. So sorry, that was a little bit tricky of me, but we'll go on and talk the reasons through this. So constipation, idiopathic constipation. We are all quite familiar with this. Definition, you can define it as infrequent passage of dry, hardened stools accompanied by straining or pain or bleeding, with or without abdominal pain. And I asterisked infrequent because the frequency of a child's bowel motions is fairly unique to the child. A rough rule of thumb, but again, it varies according to age, is that newborns, infants pass stools 3-4 times a day, and then by the time they get to about 2 years of age, they're going once or twice a day. But it varies wildly. So it really, we kind of classify once a day as normal, but it can vary according to the child. But it's really the presence of the other symptoms and the kind of dry, hard stools with with those other symptoms that are kind of that make the definition. There are several different triggers in young children who are otherwise healthy. They might not be drinking enough fluids, or they might have become dehydrated from an infection or feverish illness. They might have developed an anal fissure, probably from a previous bout of constipation, which then causes them a lot of pain when they go to the toilet, especially if they're passing hard stools. This then starts a vicious cycle of fear and pain. And it could be triggered by issues with toilet training or problems using toilets at school or in unfamiliar situations. But the bottom line is that a constipated child is usually well with it. So when you examine them, they look well, they're growing, they usually don't have a kind of big distended abdomen. So exceptions to that rule and red flags that you must look out for when you are examining children for constipation are down here. So essentially, you want to look for potential signs that might indicate a condition called Hirschsprung disease. Now, Hirschsprung's disease is a congenital abnormality where a section or several sections of the bowel are not innervated. So basically, they don't work properly, they don't move properly, and that leads to a stasis and a buildup of stools and constipation. You can get clues as to whether this might be happening if there's been a delay in passage of meconium at birth for greater than 48 hours, which is why we always ask the parent of any child with constipation whether they pass that kind of thick, sticky, black, tarry stool in the first 48 hours of life. If the child does have really gross abdominal distension, that's not normal for constipation. And if they're passing these ribbon-like stools, which are kind of long, thin ribbons of stools rather than a large, well-formed mass, because that might indicate some problems with the lower part of the rectum. Other red flags include faltering growth or developmental delay, which might indicate something like hypothyroidism that isn't congenital, or something like celiac disease. So it's always useful and important to test for both of these things. They're very simple tests that can be done on the blood tests if you are worried. And then it's important to examine the spine and the lower limbs to make sure that the neurology is all right. If there's any abnormal neurology or motor delay, that might indicate some kind of lumbosacral pathology. If there's any abnormalities over the sacrum, such as pits or hairy patches or a nevus, this could indicate a spina bifida occulta. Again, this can all affect kind of bowel anatomy and movement. In children, we look at the anus, but we don't, we certainly don't routinely do a digital rectal examination. But if the anus looks abnormal in position or appearance, then that could indicate a problem with the anatomy there. We talked about perianal signs of Crohn's disease, like fistulas, fissures, abscesses, so think about that. And do keep at the back of your mind if there's any unusual marks or bruising, then this could also be a sign of sexual abuse, and that can manifest in several different ways. So, we always keep safeguarding at the back of our mind with children. Some of you might be familiar with this lovely chart, the Bristol stool chart, which causes a lot of hilarity in clinics with children who are old enough to understand this. But it is important to pull this out and show it to the parent or the child if they're old enough, and if they look at their stools, to really ascertain, what kind of stools they're passing and what the consistency is. And really, your aim is to diagnose fecal impaction. So, as in this case, if the child has a hard lump of stool sitting in the lower abdomen, but they're having very liquid, soft stools leaking around, leading to soiling, then they are most likely fecally impacted. So, even if the child appears to be opening their bowels, but having very watery, soft stools, if they have a palpable fecal mass, they are most certainly fecally impacted and constipated. So treatment of constipation is fairly straightforward, and really, the NICE guidelines, certainly, here in the UK, are very comprehensive, and I would urge all of you to go ahead and have a look at those and have a look at the doses of the different medications there. But the pharmacological treatment is pretty straightforward. If the child is not fecally impacted, meaning if you can't feel a mass in their abdomen and they're not having an overflow soiling type of symptom, but they are having dry hard stools, infrequent passage of stools, then you can quite safely start a maintenance laxative, a macrogol, such as Movicol or Laxido. And you may need to add in a stimulant laxative such as Senna if children need a little bit more help with that. And again, the doses are all in the BNF or in the NICE guidance. If there's sign of fetal impaction, and this is where you have to start a macrogol disimpaction regime, which essentially is an escalating number of, say, Movicol sachets until the child has a big clear out, so to speak. And again, details of this, are very easily found in the BNF, so I'm not going to talk through this bit. But it's important that after the child is disimpacted, they are on regular maintenance treatment, and that's really, really important. And I'll explain why in the next slide. But you can't just stop the Movicol and hope for the best. You really do need to have a child on a kind of regular therapy that allows them to pass one soft stool a day. That's the rule of thumb, and that needs to carry on for usually several months. A rough rule of thumb is that you carry on the treatment for roughly as long as the child has been constipated. So if the child's been constipated for 6 months, you probably need to carry the treatment on for 6 months to allow the bowel to regain its original elasticity. Now, dietary interventions and behavioral interventions are good things to use simultaneously, but they're not first-line treatment, particularly if children are fecally impacted. So, so again, you can certainly use those alongside, but if child has clear signs of constipation, then they may not necessarily be all that effective. Behavioral interventions include having a structured toileting routine. So explaining to the parent and the child about the gastrocolic reflex, where after a meal, usually 20 minutes after a meal, that's when the body may want to go to the toilet to do a poo, and that's a good time for the child to sit on the toilet. If the child is of the right age, it might be beneficial for them to have some kind of reward system, like a little star chart or a sticker chart. So, often these interventions work well if the child understands what's going on and is compliant with the medication as well. Now, I cannot stress this point enough. The medication is the easy bit. The hard work starts when it comes to counseling the family and the child. You must take time to do this. If you just give the family Movicol and expect them to get on with it, nothing will happen, and you'll be back to square one, within minutes. So really, you need to take time to explain to the family and to the child, if they're old enough, what constipation is, why it's led to the symptoms they're having, and the fact that it will take a while for symptoms to resolve. It's not an overnight cure. This is quite a nice little infographic, well, in a slightly gross way, but essentially this is from Up to Date, and it kind of this is a parent information leaflet, and it gives a very clear visual representation of what's happening, and it's important that the parents and the child understand this. So on the left, you've got the rectum, the lower end of the large bowel, which is full of feces, big and distended, but you've got liquid stools kind of coming out, which is the overflow. It's painful, which is while the child holds onto the stool, but because the rectum is so stretched out and baggy, the normal neural feedback does not work that well. Okay, and that leads to this vicious cycle of more buildup of hard stool. And what you'll need to explain to the family is that the laxatives essentially soften the stool, but the child essentially needs to relearn these signals from the rectum to their brain to let them know that they need a poo, because those signals are often lost in chronic constipation. So even though the laxatives might soften up the poo, the child often needs to relearn how to recognize those signals that they need to go for a poo, which is where the structured toileting routine and regular sitting on the toilet, ideally 20 minutes after a meal, that's where that comes in, so that they associate that the movement, so to speak, and that feeling with needing to go for a poo. Once the child, if, for example, they've gone through the disimpaction regime and they've had a good clear out, the importance of maintenance therapy is to essentially allow the stretched bowel to regain its elasticity and to regain that neural feedback, which is why the stools need to be kept soft with maintenance laxative therapy, often for several months at a time. And really, if the parents and the child don't understand this and they're not in it for the long run, then you're just going to keep coming back to the same conversation again and again and again. And basically, Movicol doesn't taste nice, so kids are just not going to take it. So it's really important to have this dialogue with them and to give parents as much information as possible. What I will do very quickly is show you another really nice resource. Let me see if I can do this with a new share. It's called ERIC. So can you see that, Andrew?
Yes, perfectly.
Lovely. So some of you might be familiar with ERIC, eric.org.uk. This is a children's bladder and bowel charity. This is a fantastic resource for kids who are old enough, actually no, any child, because they've got lots of nice videos and cartoons, and they've got great videos by Dr. Ranj from CBeebies. Kids love him apparently. I don't really know who he is. But essentially, this is a fantastic resource for parents and kids, and even for health professionals, as you can see here, to signpost. And this gives lots of, let me just see if I can show you, where are we? Lots of great information about constipation, advice for children with constipation, poo problems, pooper highway, great fun. So, just talks children through nice stories, and he even tells you about bladder issues as well, but we're not going to go into it in this presentation. So this is this is a really user friendly, really good resource to direct them to. Oops, sorry, gone back to the start there. So where did I get to? Sorry. Yes, I got to this lovely slide. So when to refer? So essentially, if your child has any red flag signs that we discussed in the earlier slide, then certainly they will need referral for further investigation and potentially some kind of intervention. If the disimpaction really does fail, if parents have tried and you've given them lots of education and they're still getting very, very constipated despite your review after a couple of months, then certainly that's to refer. Very rarely, they might have very severe fecal retention requiring manual evacuation, and that's, again, very unusual. Usually, parental anxiety, I would say that's not a reason to refer. I know in reality that does end up happening, but again, do make sure that they have really good resources like this ERIC website that I just showed you. All right. I'm going to finish quickly on recurrent abdominal pain. I know we're getting to 9 o'clock, so please bear with me just a couple more minutes and then I'll be done. So recurrent abdominal pain is essentially a condition we're seeing more and more of in young children, and it does cause quite a lot of anxiety amongst healthcare professionals as well as families. So it's defined as more than 2 discrete episodes of abdominal pain in a 3-month period. And it often interferes with school and usual activities of children. And it can occur in up to 15% of school-aged children. But in the majority of cases, no organic cause is found, but it can be a manifestation of stress or anxiety. So if children are feeling worried or anxious, this can present as abdominal pain quite understandably. So that's something to be mindful of. But often on examination, you will find a child who is thriving, who looks well, who is growing, and often pointing to intermittent periumbilical pain. Some organic causes, so to speak, that might turn up include abdominal migraine, which is often associated, is abdominal pain associated with headaches. And again, the pathophysiology is a little bit unclear, but if there's a family history of migraines or a personal history of migraines, and then this could be a potential diagnosis there. Children may have some pallor and vomiting with this. I've not seen it that much myself, so I'm not very au fait on abdominal migraines myself. Obviously, irritable bowel syndrome can present in usually adolescent children, adolescent girls often, particularly around the times of stressful events such as exams and that kind of thing. So often a trigger like that. There might be an element of gastritis or peptic ulcers, especially if there's a family history. Again, unusual in young children. You can sometimes have H. pylori infection in children from certain backgrounds or certain countries. In certain ethnic groups, lactose intolerance can be present, and that can cause a kind of non-specific abdominal pain as well. Management, principles of management really are to identify any serious causes while minimizing unnecessary investigations. Because what has happened in the past is that, the non-organic elements of the abdominal pain have been medicalized very, very heavily, which leads to children having multiple painful unnecessary investigations. So really your kind of clinical examination is key here. But fairly simple tests that you can do in primary care. Well, sometimes in pain, you can do a urine microscopy and you can do blood tests like celiac antibodies or thyroid function. And you can refer for an abdominal ultrasound, which is often really only helpful in situations like, renal stones or gallstones. But again, those are actually very, very rare in young children. A food diary can certainly help to identify any key triggers, particularly if there's a kind of lactose intolerance or if there's a possibility of gluten intolerance or celiac. Really, the kind of key point is clear explanation of the condition with acknowledgement that the pain is real, but if there's no organic cause, then confident reassurance with really adequate, with good education about the condition, and obviously avoiding any stress-inducing factors or stressful events if at all possible, and giving the child and the family coping mechanisms to kind of deal with any stressors. Prognosis is a little bit variable. About half of children, their symptoms resolve quite rapidly. About a quarter, their symptoms resolve quite slowly, and about 25% have symptoms that persist into adulthood. So, again, that doesn't mean that there's anything terrible going on. It's just their makeup, and that's just the kind of symptoms they have. So again, not a fantastically well understood entity, but it is something that we are, learning more and more about. So that is today's webinar. Apologies that I've overrun a little bit, but this is a reminder of the learning outcomes, and hopefully we've kind of ticked off all of those. And these are some of the resources that I've used today and that I would direct you to as well to have a look at, particularly the nice guidance on constipation. That's really excellent one. And that's it for me. I'll hand back to Andrew. Thank you very much.
Dr. Darshana, thank you so much indeed. We've only got a couple of quick questions. First one we've got is it possible for a child to have long-term constipation that would require them to be on continual Movicol? If this is the case, what condition would cause this?
Oh, that's a tricky one. So I'm assuming you're referring to a potential organic issue. So long-term problems, bowel problems that could lead to constipation. Hirschsprung is one of those conditions, but often you'd have some kind of surgical intervention. But these children may well need to be on long-term Movicol. I suppose parts of certain presentations of irritable bowel might be, but again, it's unlikely. So, the vast majority of children do grow out of constipation unless they've got some kind of intra-abdominal pathology going on, usually Hirschsprung's.
Thank you very much indeed. Just a quick few thank yous. I've got thank you to Amy, Sarah, Andrew and Lee, who's subscribed to download our posters. We've just had 10 new members join. Tim, Lola, Mandy, Saul. Saul looks like you could be our neighbour, Saul. I think you live literally around the corner from us. Mark and Stephanie. So thank you very much indeed. We've got one more question from M. Pre-hospitally wise, would intussusception or Crohn's in the RAIF mimic as appendicitic pain, and if these occur in the RIF, could they increase the risk of developing appendicitis?
Okay, so intussusception could potentially mimic right iliac fossa pain in as an appendicitis, hence the diagnostic conundrum. But if you think about the age ranges, the chance of a child under 3 having appendicitis is quite rare. So you're much more likely in that age group to have a child with an intussusception. So I agree, there's a little bit of diagnostic uncertainty, but a lot of these issues in pediatrics are resolved by looking at the age group as well. Could Crohn's mimic appendicitis pain? No, unlikely. Crohn's does not tend to present so acutely. And if you have a child with Crohn's, they usually have a much more indolent presentation, and they often have other signs of Crohn's, such as ulcers or perianal disease or weight loss. So again, Crohn's rarely presents that acutely. Would they increase the risk of developing appendicitis? I genuinely don't know the answer to that question, but I would say no, because the appendix in itself is not related to the kind of terminal ileum, that kind of junction. So unless the child then goes on to have problems with, say, constipation and they have a fecal lift. But again, I'm not 100% sure on that note.
Excellent, thank you. And then just a comment from Elsward, not a question, but I am a children ED physician and find myself treating constipation daily. Without GP involvement, I think GP education and parent education may even perhaps at school via school nurse be essential. I think I have to agree with that.
Yeah, very valid remark. Yeah, it's great.
Yeah. Lots of fabulous comments there in the chat for you. I think everybody's enjoyed tonight's presentation, so thank you so much indeed. One last question we've got from Ben, which is there risk of chronic constipation after intussusception?
I don't think there's a linear association, but we see in children who've had, some children who have had a severe acute illness or who have had some kind of abdominal surgery, they may well have a kind of post-surgery ileus, which then leads to some constipation. So it's a theoretical risk, but it's not a linear risk from intussusception to chronic constipation. But any child that is unwell with anything, and if they're not drinking enough fluids, that can certainly cause a trigger to constipation.
Good question, Ben. Thank you. And you know me, nearly forgot about the raffle then, the fabulous raffle for all those amazing people who've left us some fabulous feedback. So I've got we actually received a complaint the other week to say that I wasn't rolling my sleeves up far enough. So honestly, like Paul Daniels, look at this. So I'm going to go in and I'm going to pull 2 winners out now, and I'll pull a winner out tomorrow. So first winner, I'll have to get an independent adjudicator. It's getting a bit like the National Lottery. First winner is Neil Robinson, Trustpilot review. Neil, drop us a message, andrew@cpdme.com, and we will get you your Trustpilot, your £25 voucher. I think they come digitally, to be honest with you, so I think we just need your email address, Neil. And the next one, oh gosh, look, this is when the complaints come, and I take my hand out of the way of the camera. Then the next winner is, gosh, honestly, the things we do. Gosh, they must have the stickiest paper ever. Ben Taylor, Trustpilot review. Fabulous, Ben. Thank you so much indeed. The rest of the people, I will leave in that little plastic raffle bag, and I'll do one live tomorrow because I've no doubt some people might leave us a review overnight tonight. So, Dr. Darshana, all these minutes to say is thank you so much indeed.
Thank you very much, Andrew. Thanks, everyone, for joining.
I did pop a note in the chat for Dr. Darshana, so that actually, if you want to join us, you can join us because I think we've got Dr. Darshana and Dr. Blanche joining us on the 12th of March for the Saturday Symposium. So you can scroll up the chat. I have popped something in the chat. So please do grab yourself a ticket for that. I think we've got 32 tickets left for that event, and then it's a sellout. So 3 hours of a Saturday Symposium, spotting a sick child. And I think I also popped in the chat, or one of my team popped in the chat, the actual download of the agenda for the day. So please don't miss out on that. Right, I'm going to show you what happens. If you're interested in seeing what happens when your CPD certificate arrives in your app, stick around, and I'm going to show you now how recording your CPD is super simple. Now, this is where the tech...
I might sign off then, Andrew.
You can sign off, Dr. Darshana. Thank you so much indeed.
Thanks, everyone.
Take care, lovely. Speak soon. So, let me try and share my app screen to the desktop, and this is where it normally spits its dummy out, but we're going to have a go. Oh, look at that. Look at that. That is impressive. This is the point normally when my mum rings up, so stand by. So if you've downloaded the CPD Me app, this is what it looks like when you sign in, and I can see my dashboard over the last 12 months. Tomorrow at 10 o'clock in the morning, when the team send out the CPD certificate, it will create an automatic diary entry. So you can see at the very top of my screen there, it's already created the Paediatric Abdominal Acute Chronic presented by Dr. Darshana Bhattacharjee. And if I click on that and click preview, you can see my PDF is there. There's not very much text on it because I haven't written anything, but equally the certificate is there at the back of it. So there is your diary entry or your entry in your portfolio, and there is the certificate. So what do I need to do to bring that up to date? I click onto it. I click onto edit. I then modify the entry. So I'm going to put 1 hour of CPD. We've gone over a little bit, but I'm going to be generous. Just 1 hour of CPD. And then I'm going to click onto save and continue. I pick my governing body. So because I'm a paramedic, I'm going to choose the HCPC. I'm going to click onto save and continue. And this is where recording your CPD is super simple. I can click into that box. I can click the little microphone at the bottom right-hand corner, and I can tell the app what I want to write. So taking part in this webinar this evening around children presenting with abdominal pain will help support my practice when it comes to assessing children presenting with abdominal pain of an idiopathic nature, full stop. Understanding better pathologies and illnesses surrounding children presenting with pain around their abdomen region will better improve my clinical practice and as a result, improve patient care. Now, I just come off with that off the top of my head. There's probably a couple of spelling mistakes in there, but realistically, if you line up in your head what you did, why you did it, and how it's going to improve your practice, you can pretty much capture a reflective piece in a couple of seconds. Click on save and continue. You can then map that to my HCPC standards, and I always say to people, don't just click it because it's easy. Make sure that you're clicking these boxes because it relates to the particular activity. Click on to save and continue. If there's a website, you can put in there cpdme.com if you like. If you want a reminder to review this entry in 12 months' time, then click that little box and the app will send you a reminder. If you want to capture more evidence, you can click onto capture. And the great thing about the capture is it's got a document scanner. So you can scan with a document scanner, whether that's another certificate or maybe a thank you letter. So you can see there that my screen has perfectly captured that thank you letter. Now, we have to remember in thank you letters, it can't contain anything patient identifiable. So click onto next, and then the app will say to you, would you like to censor any part of this evidence? If I click onto yes, it then allows me to grab a little black box and cover anything in that letter that has anything patient identifiable in there. Click onto done. It then allows you to very quickly upload additional evidence. That could be a certificate, could be a bulletin, it could be a book, it could be anything in fact. Click onto save and submit, and your entry's been saved. And then when you go back to the front entry, you can see there now that it's almost complete, 88%. If I click into it now and click preview, you should be able to see that actually, in fact, let me make it 100% for you. So let's go through the entire entry. So arranged in, I'll put myself in my own time, save and continue, save and continue, save and continue, save and submit. And then hopefully that's now gone to 100%, 1 hour of CPD. And if I click onto it and click preview, you can see my print ready copy of my portfolio is there. So that would be what I put in my portfolio. And then my certificate is there. So it's created a simple entry in less than 3 minutes, including evidence, time, date, title, and the amount of hours of CPD that it's taken. So please do download the app. I promise it will make recording your CPD simple. For anybody who knows me, you'll know that this was my research back in 2009 to make recording CPD simple. So please take this amazing opportunity to download the app or join us this evening. And again, jump over to the website and have a look at our up and coming webinars. We have got rakes of webinars lined up. Off the top of my head, we've got theory of medical education, we've got prioritizing leadership in healthcare, we've got rethinking gender and dementia, we've got lessons learned from COVID, as well as another amazing lineup of CPD webinars coming soon. And hopefully next week, I'll be in our new office because we're jingling around. So on behalf of myself and all the team here at CPD.me, thank you so much indeed for your continuing support. Thank you so much for leaving us some amazing feedback on Trustpilot. Thank you for those girls and guys who's joined us tonight. And please stay safe out there. If you are at home and you are relaxed, kick off your slippers, enjoy the rest of your night. If you are working, then please stay safe and ensure that you keep each other kind, warm, and be kind to each other, more importantly. Take care, everybody.